Hi, Paul Baldwin here. Today we're going to review the final rule for the reform of requirements for long-term care facilities. And this is specific to members of the long-term care pharmacy community. And we'll get started right now. This rule is the first major revision of requirements for participation in Medicare and Medicaid for skilled facilities since 1991 and represents a major regulatory update for nursing homes. Since this represents a major update, CMS has agreed to phase in the requirements of the new rule over the course of 3 phases. Phase 1 begins on November 28th of this year, Phase 2 November 28th of 2017, and the final Phase 3 begins on November 28th of 2019. Let's make a couple of quick observations. If you read through the rule, it becomes clear that CMS has placed a high value on the contribution of pharmacists to the well-being of nursing home residents. We will highlight these provisions in this review. Second, this rule adds to an increasing load of regulations and programs emanating from CMS on the nursing home community, such as value-based purchasing, the Impact Act, bundled payment initiatives, and reductions in rehospitalizations. This list is long, places considerable stress on the facilities we work with. Let's begin by drawing our attention to the definitions section. There's a relatively long list of definitions, but there are a few that are especially important to keep in mind as they will guide how regulators enforce particular provisions. Important definitions include abuse, adverse event, as well as the definition of a licensed health professional, which CMS takes pain to note, is defined in the Social Security Act, which does not include pharmacists. Other important definitions include neglect, person-centered care, and transfer and discharge, which guides the implementation of medication reconciliation requirements. Together, these definitions highlight what CMS means to convey when they discuss new regulatory mandates and are important for us to be familiar with. Advancing and protecting nursing home resident rights is a high priority for CMS, and the agency has created robust regulatory provisions to promote these rights. CMS intends that residents will have a right to be engaged in their care and will have the right to direct the care they receive, or even to refuse care when it's offered. The admission, transfer, and discharge section contains a provision we should be aware of. Upon transfer or discharge, CMS requires that the nursing home communicate important information to the receiving healthcare provider. Among the documents that need to be sent to the receiving provider is a discharge summary, which CMS notes must include medication reconciliation. The idea of person-centered care was briefly discussed in the definition section, but CMS devotes a significant portion of the rule to providing instructions on how this process is to be implemented. The creation of a baseline plan must be implemented in Phase 2, or November 28, 2017. This baseline plan includes a summary of medications, and the baseline plan must be submitted to the resident and his or her representative. It's clear that pharmacists will need to work closely with the clinical staff of the nursing home to create both the baseline plan and the comprehensive care plan, not only for purposes of this rule, but for other CMS initiatives currently in place, such as the reduction in rehospitalization program. Quality of care is another important section of the final rule and covers a lot of ground. We won't go into a full discussion of all the provisions, but 2 items are of particular interest to long-term care pharmacies. The administration of parenteral fluids is an area of focus. CMS notes that this is considered a key area of quality. Also, pain management is an issue that CMS wants nursing facilities to focus on. However, it should not be lost on any of us that this requirement frequently creates conflicts with the priorities of other federal agencies. The pharmacy services section is one which is of most immediate interest to our community, and the CMS begins by noting that the pharmacy services provisions will be assigned to a new section, 483.45, from its current listing at 483.60. It's a section worth reading, and we will now go into these provisions in some depth. First, note that CMS will require a medical record review as part of the monthly drug regimen review. This provision becomes effective in November of 2017. The agency will also require a pharmacist review of psychotropic drugs, which the agency defines as including but not limited to, antipsychotics, antidepressants, anti-anxiety drugs, and hypnotics. CMS noted in the preamble that there were many comments to the proposed rule about this definition, and it made alterations that will likely make the final provision less expansive than the proposed rule. Not only does CMS require inclusion of the medical record review in the monthly drug regimen review, but it also expands the requirements concerning how the pharmacist's report of irregularities is to be handled. Once the pharmacist's report is complete, it must be sent to the attending physician as well as the facility medical director and the director of nursing. The attending physician must note in the resident's medical record that he or she has reviewed the report and what action has been taken. If the physician does not take any action, an explanation must be provided. Continuing with the monthly drug regimen review, CMS decided not to be prescriptive on the exact policies each facility must implement with respect to the review, but will require the facilities to establish specifics concerning the timelines for each step in the review process and how the pharmacist is to respond to irregularities that may be life-threatening. The defining mission of the drug regimen review is to identify unnecessary drugs. CMS notes that an unnecessary drug is to be defined as any drug when used in excessive dose for excessive duration, without adequate monitoring, without adequate indication for its use, or in the presence of adverse consequences which indicate the dose should be reduced or discontinued. Under the new rules, the facility has a responsibility to monitor the use of psychotropic drugs among its residents. First, CMS wants to ensure that residents who have never taken psychotropic drugs are not prescribed these drugs unless there is a documented medical reason, which must be entered into the medical record. For residents who have been prescribed psychotropic drugs, CMS intends that there is an attempt to reduce dosage and try behavioral interventions with an intent to wean residents off the use of these drugs. Finally, CMS wants the facility to prevent the casual use of these drugs under routine PRN orders. Therefore, there are to be no PRN orders for psychotropic drugs in the absence of a documented indication for the use of these drugs. Continuing with the PRN provisions, CMS will require that PRN orders for psychotropic medications be limited to 14 days. Extending the order beyond 14 days will require a prescriber to document the need for the extension and indicate the period for which the extension applies. Finally, CMS requires that medication errors in the facility be limited to a rate of occurrence of 5% or less, and follows with a general requirement that residents be free of any significant medication error. Under the administration section of the rule, beginning November 2017, CMS will require facilities to perform an assessment to determine what resources are necessary to competently care for the residents. This assessment must be reviewed and updated at least annually and includes the pharmacy services provided to residents. Pharmacies need to be aware that there will now be a formal requirement for the facility to do an annual review of its pharmacy services, and this should be an additional incentive to ensure that pharmacies are providing sufficient support to keep the facility compliant. The quality assurance provisions of the final rule, while not specific to pharmacy, represent the continuing burden on facilities to manage CMS requirements concerning identifying and responding to resident adverse events, which include medication-related events. Current CMS focuses on preventing unnecessary hospital readmissions and preparing residents to return to the community when and if it is possible to do so. Pharmacists have much to offer in this area, and our efforts are essential to help the facility achieve its objectives. Infection control is another initiative CMS is introducing into the final rule. An antibiotic stewardship program must be implemented in each facility by November 2017. This requires facilities to develop protocols for the use of antibiotics, as well as a system to monitor the use of antibiotics. Pharmacists may be expected to be included in the implementation of this requirement. CMS also requires that each resident is provided information on the benefits and potential risks of immunization for influenza and pneumococcal disease. This educational activity must be documented in the resident's medical record. Finally, CMS will impose a training requirement on facility staff as well as contracted service staff, which will include pharmacists who provide services under contract to the nursing home. With the exception of abuse, neglect, and exploitation training, which becomes effective in November of this year, the training requirements will be phased in over the next 3 years. On a final note, this rule caps a year of extensive rulemaking and program initiatives for CMS as it seeks to improve outcomes and reduce costs in long-term care. The facilities you serve are under significant pressure not only to improve their performance, but to demonstrate to CMS that they are implementing these measures. Pharmacists and contracted pharmacies can be vital partners in helping these facilities comply, but it will require all of our focus in the coming months. Thanks for taking the time to review this rule.